Super. Thanks, Kim. I really appreciate the opportunity to be here today with you. With a group of like-minded, passionate individuals who want to do something good for the world, in addition to all of your various professions that you're coming from. So this is a great opportunity and a great theme, actually, on lifestyle interventions, where all of us from our various backgrounds can actually make a lovely contribution. If I fall off the path during the session, you'll forgive me. I just flew back from India yesterday. I was there for a few days, developing a collaboration to set up cardiac rehab in the north of India in Chandigarh. And actually, the specific project we're trying to launch is having a dentist who's doing a master's in community health prescribe exercise to people recovering from angioplasty. So that's a good interprofessional education kind of construct for us to set up. So if we can achieve at least half of that level by the end of this, then we're doing pretty well. So a little bit of background about exercise medicine, if that hasn't been done in previous sessions, Kim. But overall, so as Kim has already introduced, that this is a kind of a large effort around the world. And the Canadian arm of this, there's actually an office in Canada located in Ottawa. And the vision is that physical activity should be a core part of the prevention and treatment of chronic disease in our health system. So it's something that doesn't get a lot of attention, unfortunately. So for my discipline of medicine, it's only recently gotten some traction, but as recently as 5 years ago when we approached the curriculum committee about introducing exercise as a topic, we met with some resistance and we were told, well, there really isn't room for that in the curriculum. In a 4-year curriculum, there wasn't room to talk about exercise for now. It's kind of a sad sort of statement, but yet we recognize that for every condition that we might be dealing with, for every person that we meet in our professional and personal lives, this can actually be a powerful intervention. So let's work on that. The overall program of exercise medicine in Canada is trying to increase the number of healthcare professionals from all disciplines I've added who are assessing, prescribing, counseling patients in physical activity, and all of us have a role, maybe at different levels, but all of us clearly have a role in this, so that ultimately we can have all Canadians embracing this in their regular lives, and then specifically if you look at Canadian physical activity guidelines or Canadian sedentary behavior guidelines, that every Canadian will measure up well against that, and you look at some background statistics just to set the bar around this. And then connecting with the card-carrying exercise professionals in the room or in the community, that we should leverage their expertise as well, whatever background that we come from. For instance, I have the opportunity of working with wonderful kinesiologists on a daily basis, and they're the ones that are developing programs. Clinicians, nurses, physiotherapists, physicians work alongside our psychologists and social workers and dietitians, along with our kinesiologists, and the group together is a whole lot stronger than any part on their own. So IPE in action is definitely a critical element of this. The specific exercise medicine on campus initiative gets us going early, and these are great opportunities, and it's wonderful to see that there are so many interested individuals in the room that kind of share this vision of having more Canadians active and doing well with their lives. To set the context, if we draw a quote, and this is from the task force chairman in the US, Bob Salas, and he would purport out there that, what if there was one single prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, obesity? What if there's one pill? We'd all be running madly to find this one pill. Of course, we know what this pill is. It's not a pill. It's actually exercise, and would we prescribe it? We certainly should. But there's a really large gap in terms of what we think we should be doing and what we are doing. And we can take a step today. By the end of this evening, you will narrow that gap appreciably. Do some background, scary statistic kind of stuff, okay? So here is why people die today in Ontario. And I think you recognize this. So whatever discipline we're in, we will encounter people living with chronic conditions. And whether it's professionally or personally or in your family, we know that 80% of all deaths in Ontario arise from chronic disease. There are 4 major chronic diseases that we talk about: cancer, heart disease, diabetes, lung disease. And these comprise about 80% of all the reasons that people die. What's important about these conditions is that they all have a common root, don't they? If we think about diabetes, cancer, heart disease, lung disease, if we look at the foundational roots of why those things happen, why they come to light, I think you recognize this, that often we spend our time focusing over here, and this is what the healthcare system often is oriented around. Let's find people with disease, let's give them medications, let's put them in hospitals, let's give them surgeries, for instance. And that's the way we manage disease. But I think we recognize that for these kinds of conditions, that really if we go upstream and think about why did we get into trouble in the first place, that around the world we can recognize it's health behaviors that drive the development of chronic disease. So what we smoke, what we drink, what we eat, and whether we move or not, makes you reflect on what you're eating right now, doesn't it? Really drives on development of disease down the road. And if we really want to have an impact, maybe we should move upstream. This is the call from the World Health Organization, it's the call from the UN, it's what the call is from organizations like Exercise Medicine Canada. Let's get to the roots of the problem and try to deal with them. And some smart people that work at the Institute for Clinical Evaluative Sciences in Ontario, some epidemiologists have looked at what is the potential gain if we do these things and we do them well. So for the typical Ontarian that is starting to develop bad risk behaviors that then predisposes them to develop risk conditions and chronic disease, if we can work on smoking, alcohol, physical activity, diet, and stress as well, that cumulatively what this will give us is about 10 extra years of life, of quality life. So who wants to live an extra decade of life? And who wants to live that well? So the power to change is early, so we're glad that we're at this stage in our careers where we can actually talk about this, embrace this, and change everybody around us to become as healthy as all of you are. And this is what's kind of at the end of the road here. And for me, it's never too late. So even for an old guy like me, that there's really good data that, even at our middle years of life, that we can really bend this curve in a big way. I'm destined, if I smoke, if I drink too much, if I eat poorly, and if I'm inactive, that there's virtually 100% opportunity for me to develop heart disease over the next 2 decades. 100%. But actually, I can change this curve dramatically, 80% or more, just by choosing the behaviors that I engage in today. So it's never too late, and we can have a really, really big effect. We're indexing physical activity as a large construct, right? These are the things that we engage in with programmed exercise, plus all the things that we engage in on a regular daily basis, and total that up as physical activity. And I think you're all familiar with this guideline, right? 150 minutes. Is everyone familiar with that? You can espouse that at the end. One of our learning objectives by the end of the day will be you can cite the physical activity guideline, 150 minutes. And that's a good foundational basis for aerobic activity, moderate or vigorous. In addition, the guideline would recommend that we do a couple days of resistance training, weights, free weights, bands, machines, whatever it might be, your own body weight. Do that a couple days per week. And then the other important part of the guideline that's not stated, of course, is that you do this and you repeat it and you repeat it and you repeat it, which is the most important part of the prescription, I would argue. So there's a physical activity guideline, and we'll return to that later on. Why do we have such a guideline? And although it's kind of clearly stated as 150, we're going to talk about some data as well that's really a continuum. Every little bit counts. There is this kind of threshold at 150, but this is kind of data. If we can get up to at least that level, this goes back to Bob Salas saying, what if there was one single intervention that could reduce the chance of developing high blood pressure by 33 to 60%? What if you could reduce diabetes by half, or heart disease by half, or stroke by a third, or reduce the risk of colon cancer by half, reduce the risk of mortality and recurrent breast cancer by half, reduce the risk of Alzheimer's disease by 40%, reduce depression as much as any pill might, and reduce the risk of dying early by about half. That's what's in the cards for exercise. That's why everybody should be engaging in this on a regular basis, because that is powerful. And instead of looking at one drug therapy that might target one of these conditions while exacerbating another, why don't we have one exciting therapy that can address the whole range of illnesses? Is this a new idea? You're here all in this room doing this wonderful cutting-edge seminar, right? Is this a new idea, though? Are we really rediscovering things that we should have known for a long time? And in fact, if we just kind of go back in history a few thousand years, We recognize that we were actually programmed for physical activity. That's the way we were healthy. And if we think of hunter-gatherers, that the way that they survived was to eat infrequently, go chase down whatever you were going to eat, and cover in that time 9, 10, 15 kilometers per day to gather things, or to actually hunt things down, you'll go another 10 or 25 kilometers per day. So covering large distances, you're spending most of your time active, and you're staying pretty lean in between. And humans are programmed, that your bodies are actually designed to do this. When we evolved, so to speak, in a societal sense, and we developed an agrarian kind of culture, we developed farms, we still had lots of labor involved in the beginning. And folks would have to farm from sunrise to sunset and put in lots of physical activity to grow the crops. So we didn't have to run around, but we still walked around the farms. And we know that these folks were quite healthy. And we have models of both of these sorts of kind of older societies today. So if we look in hunter-gatherer societies in sub-Saharan Africa, for instance, where they are running around gathering foods at different times, they're extremely healthy and have low incidence of chronic disease. If we look at Amish communities that have farming cultures with low use of kind of automated machineries, then they will typically cover 14 or 18,000 steps per day versus the typical Canadian of 3 or 4 or 5,000. And they have a very low incidence of obesity, low incidence of diabetes, low incidence of heart disease that is associated with these things. So there are models that we can turn to say physical activity has been beneficial. Evolution, as we recognize, has maybe been contrary to our health. And while we seek out simple ways of doing things, we may compromise our health by doing so. So, how much time are we vested in leisure time? Or how little physical activity are we getting? So it depends on if your kind of perspective. Are you an optimist? Are you a pessimist? Do you believe data? Do you believe that people are telling you the truth? So in the Canadian Health Measure Survey, when several thousand Canadians were surveyed, adults would say that they were reporting moderate to vigorous physical activity. 52% of Canadians said that they were getting enough physical activity. What is your response to that? What do you think?
I think it's an overestimate.
You think it's an overestimate because you're a skeptic. Clearly you're a skeptic in the room. Doesn't believe 58%. Anybody else?
I
Sir?
don't believe it either.
You don't believe it either. None of you are a real skeptic.
Well, I mean, I guess I hope to get a little more information, mod to vigorous. You mean what's the heart rate that you're talking about and how long, and I guess I added a little more information.
Great. Okay. Well, thank you. So let's prime this. So already you're skeptical, though, yeah?
I believe they think they're getting that.
Okay. So people believe that they are doing things, but people misperceive maybe what they're doing. And on surveys, there's this bias to report up healthy, right? If they're asking me, am I healthy? Sure, I'm healthy. But your sentiments are correct. So if we ask a little bit more, so are they getting to the different kinds of criteria? For instance, if you set a threshold, are you at least getting 10,000 steps, whatever the quality of those steps might be? So if you objectively quantify what people do versus what they think that they do, then that number might drop to 35% of Canadians getting 10,000 steps. If you ask them, are you getting 150 minutes of moderate or vigorous physical activity so that your heart rates are getting up to 70% of your heart rate reserve, or you're getting to a point where you're sweaty and a little bit out of breath, in bouts of at least 10 minutes, then it's about 15% of people that are actually meeting that threshold. And if you're asking about people that are getting 30 minutes of moderate vigorous physical activity per day in 10-minute bouts, at least 5 out of 7 days, then that number drops to about 5%. So it depends on how you ask the question and the results that you'll get. And when you see data like this, then we confirm your skepticism that came to the room. Any other thoughts about reflections about this kind of data? These are your colleagues in Canada. These are people living around us. Maybe they're on campus at this point. Who knows? They're not in the room, are they? What do you say to statistics like this? To me, I say this is great. This is great for a session like this because it means that 95% of Canadians are not kind of getting the dose of physical activity that you would all recommend and that you are all probably doing, right? There's a bit of peer pressure that you're all doing. And what it sets up is that almost everybody that you meet in whatever setting that you're in they're right for this conversation. You don't have to think about screening, case finding, is this the right conversation to have? It is always the right conversation to have, no matter where they are at. This is what is such a great opportunity here. And indeed, Canadians are liars. Thank you very much for pointing that out. The flip of this, of course, is that many people are very sedentary through their days. And we can consider those as two kind of related axes, but maybe independent axes. Because we know, and maybe we are all examples of this as well, as being busy students, right? That you can get in your workouts, but you may also end up spending a lot of time in the classroom or doing homework in front of a screen of some sort, binging Netflix maybe. So you can be very, very active, but you can also be very, very sedentary at the same time. And we know that they independently carry risks. So it's good to not be sedentary, it's good to be active as well, and just remember those two related constructs. Why also is this really important? Is there any other data that we'd like there to the conversation? And this is a survey of 13,500 women in Australia looking at population attributable risk. That is, if I look across the whole population, what is going to kill me? All right, what's the single most important conversation that I need to have? And is it about smoking? Is it about physical inactivity? Is it about body weight? Or is it about blood pressure? All of these things we recognize as extremely important. For instance, if I was chatting with a smoker in front of me today, right now, I would say that the conversation topic really should be about smoking. Because there's no single thing that would be more important than helping that individual to stop smoking. All right, that's a given. But across the population, if we think about the number of people that smoke versus having physical activity versus having high body mass index or high blood pressure, multiplied by the magnitude of effect in terms of changing that behavior, that's how we get to population attributable risk. So for the middle-aged group, for instance, or even as we get past our mid-20s, the single most important thing is physical inactivity to be addressed. Why? Because that's the most common thing in the population, and is also a very powerful risk factor. At the low end, for instance, we have things like high blood pressure. High blood pressure is extremely important as a medical condition. Extremely important for us to find it and to manage it well with lifestyle and other approaches. But because it doesn't affect everybody, it does not become the most important population thing. So the one single conversation we need to have is around physical activity and try and change the face of health in that way. This slide talks about, well, how much do we really need to do? We have this line that 150 minutes might be the place that we reach for, but is that where all the business is? And this curve takes us through mortality on the y-axis versus fitness level. You could substitute minutes of activity, you can substitute intensity of activity, but there's this curvilinear relationship that's apparently there more promptly for men than women, but it's there. So one observation might be, boy, as you get fitter, you do more, you're more active, then the risk of cardiovascular mortality or mortality overall goes down. You with me with that? Be fitter, live longer. That's point number one. Point number two, though, that I'd like to point out from this slide is, where do you get your most benefit? Is it from taking the step from here, that is from inactive to a little bit active, or do you get it from here, running a half marathon to running a full marathon? Where do you think? Where do you get your biggest mortality benefit? Here, vote. Vote, be active. At least raise one arm. Okay, that's good. And how about over here? Can we vote for that one? Right, so we're all in this together, right? So what the point here is, though, although we set a threshold around here, 150 minutes, that's where that would correspond, the biggest benefit for the population is probably that first step. So 150 minutes is a good idea to strive for, but if you have a completely inactive population, maybe the piece of counseling is, can we find 5 or 10 minutes today? And that single activity, getting off the bum, starts to move our curve in a big way, and the biggest step is at the beginning. All right? At this end, it really flattens out, and we may not get much more mortality benefit at this end. And if you push this even further, you know that we start to have a little bit of a J curve on this thing, so that there are some perils. So there's a sweet spot. First step is often the most important, and that becomes the hurdle, right? Because when we start to think about physical activity, exercise, counseling, the person at the other end thinks, well, that means put on gym clothes, that means put on spandex, that means buy gym membership, that means going somewhere special for this activity called exercise. Where really what we might be talking about is, can we put on some comfy shoes and just go outside and then come back in? And that's a good start. That may be the construct that will actually make a difference for a population. We know that sitting increases cardiovascular disease, diabetes, and death. And this was an article that one of our PhD students wrote with our group. If you haven't seen it, this was actually one of the most highly cited papers of last year in terms of lifestyle and exercise. It actually was quite exciting. You know it has penetrance when people like Jimmy Kimmel will pick this up. I don't know if this is, I won't go to the net at this point, but on your spare time, if you Google sitting will kill you and just watch this, he's done his own take on why sitting is such a bad thing for you. But that's nice. That's knowledge transfer in action when you cross out of the medical world into some place where it actually makes a difference. Why is that important? It's because we are really good at sitting. We're spectacularly efficient at it. And if we put like EMG electrodes on you, on different parts of your body, and watch what happens. So when we're standing, we think we're standing still. But there's actually a lot of muscular activity that still goes on to keep yourself in this position, right? There's balance correction that happens all the time of large muscle groups in the legs and the trunk, just trying to keep yourself stable. Some of us, as we get older, will do this even in a more exaggerated way. So that's what this kind of EMG activity kind of reflects. In the middle, though, is what happens when you sit. And all of us right now are spectacular. You've perfected the art of sitting. And you can sit without moving nearly a muscle. And you can think what happens when that happens metabolically, which is very, very exciting when it comes to that. But then when we stand, we start to move all this stuff again. So some of the literature that would show would be that, why is sitting such a bad thing? Well, when we're doing this stuff, we get metabolic derangement really, really quickly. We can do studies, and people have done studies on university students. If we change your activity just for 3 days, make you inactive, that your response to a standard meal, your ability to bring in glucose and mobilize insulin to appropriately handle things changes dramatically, about a 50% difference. That you develop kind of pre-diabetes within 3 days of just not moving. It's wonderful, the experiments you can do on university students. So how do you turn that around is just making sure that we do stand up, that we do move on a regular basis, sit actively might be the other thing that we do. And then I've been running with this kind of thought for a while now, that we have this undue emphasis in society on exercise is dangerous, right? Do any of you know what a DVD is anymore? No? So in the old days, we used to have these silvery discs that went into machines that would show a video, yeah? And when you do that, and it was something around exercise, then the first warning message that would come up, and you can do this, of course, online now, pull up any exercise video. Usually the first message that pops up is what? This yoga class will kill you, right? Please consult with your physician before you do this. And over again, we have this message propagated that exercise is a really, really dangerous thing. We never tell people, well, sitting on the couch is actually a really, really dangerous thing. None of you signed the waiver today that sitting here was actually elevating your risk of death and diabetes and heart disease just by sitting here, let alone adding in some carbohydrates and some other tasty bits. So we need to get to this kind of interesting kind of construct, right, where sitting is really the dangerous thing for us. So maybe this is like the brief counseling tip number one. Wherever we're at, whatever discipline we're coming from, if we're looking for just like quick tips. So if you're a dentist and looking at somebody's mouth, the immediate kind of response is, once we're done here, not right now, but once we're done, please stand up. And make sure you do that. And whatever circumstance you're in, find the opportunity to stand up. All right, that's tough right now for us in this room, but usually during these sessions, for anybody that wants to stand up and go to the edge of the walls, feel free to do so. It's all fair game. So there it is, time for a stretch. Anybody want to take us through a stretch? Any brave individuals want to do that? No? Okay, why don't you just stand up? You'll do the stretch. Thanks, come on down. Nicely done.
I don't know, so I just go by the image.
Okay, do whatever feels good to you.
Gonna lead it?
Do whatever feels good.
So Yeah, we're gonna do a stretch. The first stretch is moving your head forward and backward. So what you can do is count to 3 and move it forward, then count to 3, moving it backward. So we'll go forward. 1, 2, 3. 1, 2, 3.
Outstanding. Wow, good job. Good job. So whether you move or whether you don't move, standing up for 30 seconds is always a good idea. It also keeps the people awake that are falling asleep at this point. So there we go. It's harder to stand and sleep. Okay. Good. Again, anytime you want to stand up, please do so. Okay. So if we get to the part around what can I do in terms of a consultation, so is everyone on the same page? This is probably a good idea to actually get up and move, and it's so simple, not good stuff. Did we have to come here to listen to this? So how about part 2 of this is, how do we get to a framework for counseling, and what difference might that make? And that's kind of interesting. So if we put things in the right sequence, then we can achieve good outcomes. On the other hand, sometimes if we try to push hard on a behavior, the response is something that we might not expect. And I guess the analogy would be, who here has a parent who tells them what to do? Who here enjoys that interaction of having your parent tell you what to do? They're well-intentioned, lovely people, aren't they? They have whose interests at heart? Your interests at heart, yeah? They really would like you to succeed, really would like you to fulfill your dreams. They only have good intentions. But what do you do when they tell you what to do?
The opposite.
You resist, yeah. Why is that? That's human nature. You could even do this experiment where you fist bump with the person next to you. And if you start pushing hard against the person next to you, the immediate reaction is that they push back. And that's human nature. So we need to have a different kind of construct to this. So when I went to medical school, how many times have you heard that? When I went to medical school, the thing I learned was, top of the food chain, right? This is, all you need to know is that once I have some initials after my name, then I just have to tell people what to do and they'll do it. And for many years I tried that around like physical activity counseling. I would see a patient and say, you've got diabetes, you've got heart disease, the single most important thing for you is to get active and moving. Good luck. I'll see you in 6 months. When I see you in 6 months, what's happened in that meantime? Have you got more active? Have you got more engaged in that? The answer would be no. Why? Because 1, they may resist the good advice that I'm giving them. 2, we also haven't really come to a reasonable kind of framework. So if we have a few more minutes to invest, then we might think about some of these things, right? And you all go through this yourself. Who's active on a regular basis? Who started exercise? Who stopped exercise? We all go through these kinds of things. So if we put this into a framework, we might think, well, let's figure out who we're talking with. That's kind of screening. Do they have any conditions that might be of concern? Where are they at? And kind of stages of change and trans-theoretical models of change. You may have heard of these things. Let's have a discussion on what we mean by physical activity. Does the person have in mind, this means go to a gym, and they're never going to do that, therefore they will never exercise? Or do we really mean put on your shoes and go outside and walk about for 10 minutes? That's what physical activity is. Think about why be more active, not for our perspective, but from the client's perspective. Think about the pros and cons of this, because there are pros and cons. In our minds, it's just all good, but from the client's mind, it might be something different. Think about barriers up front. If we don't think about them, then they'll never be addressed, and then folks will never be kind of successful with that. Where are you at now versus where do you want to be versus what the guidelines might say, and kind of come to a discussion around, there's a discrepancy here. We're going to dive into some of these topics in a second. Then, and only then, might we actually get to a prescription. All right? So that's kind of an interesting stages to get through. Identify some opportunities, assess and develop some self-efficacy, which is really the goal here. Develop long-term goals, find support, and then think about relapse. That seems like a lot of work. So, are there some pearls that we can distill out of this? So, one, around the screening part of this. The population that I work with are recovering from heart attacks, have had angioplasty, have had heart surgery, have had heart failure. Some of them have had such bad heart failure that they've required implantation of a pump into the left ventricle, and their hearts really don't beat anymore. Instead, it's a little Moulinex that whirs around and drives circulation around the body. You don't hear pulses anymore. It's just this little flow, continuous flow. We exercise those folks. So there are very few circumstances where we don't want to promote exercise, and we have to kind of get over that. But yet, when you pop in the exercise video, it says, don't do this. This can be really dangerous to you. We would propose that it's far safer to get you going than not going in terms of your longevity and well-being. There's a few conditions that we do need to be thoughtful about. If you're having crushing retrosternal chest pain right now, it's not a good time to exercise. If your heart is going 150 beats a minute right now, not a good day to exercise. If you can't breathe because your lungs are full of fluid, not a good day to exercise. If you've got an acutely inflamed knee, not a good day to exercise. If your sugar is 30 today versus the normal of 5, probably not a good day to exercise. But then otherwise, it's probably a good day to get out there, irrespective of what else is going on. Usually much more risky to be sedentary than not. Trans-theoretical models, anybody know this? Prochaska, change models? Yeah. Give me some more vigorous, yes? Okay, good. So I don't need to think about that too much. I'm glad that you're familiar with it. And we remember it about, pre-contemplation, contemplation, getting preparation, doing action, maintaining, right? And sometimes we think about it as a linear thing, right? I need to get somebody from here to here to here to here before they will be successful. And that's a thoughtful model that's been used in many, many disease conditions. The other way, though, I'll think about motivation is this. Motivation may be more like whack-a-mole. That it just pops up at random. And we just have to be prepared to hit it on its head when it pops up. So it's not sure that you're talking to somebody and they say, no, but then something happens today and suddenly they're motivated. That's great. So they don't have to move through all those stages. They could have been a pre-contemplator for a long time, but then suddenly today they're ready for action. And just be prepared for those wonderful opportunities when that comes up. Think about the description of exercise versus physical activity. And some people don't like to exercise. They don't want to think about that planned, structured, 30 minutes at the gym kind of thing. But then recognize that physical activity in our daily lives, that can be extremely powerful as well and can deliver most of the health benefits that we are talking about. Get into structured activities, we can do more, but this is a lot of stuff that we can do. And maybe this is what the prescription is about. When we don't use any more time for anything, but just leverage the things that people are doing in their regular daily lives. So time is the barrier, this is the solution. Just live your life differently without actually adding any time or burden to it. We might ask people to do this kind of exercise, and maybe you're going to do it kind of in the scheme of case studies, but this might be a worthwhile exercise. We can think of reasons. Anybody want to throw one out? Why be more active? Why exercise on a regular basis? Why? What's it do for you? Or what do you think it does for you? Back row? Sir, yeah.
Better sleep.
Sleep. Good, because you like to sleep. Yeah, it's important. Yep.
More energy?
Energy, sleep, and energy. Two sides. What else?
Save money on TTC.
Save money on the TTC. So save money. It doesn't cost you money. You actually save money, which is brilliant. Anything else?
Confidence.
Confidence. It builds up self-confidence, your ability to do things. Absolutely. Anything else? Happy. So that's great. So good for mood. So none of you have talked about heart health, cancer prevention, diabetes. You're far away from developing those conditions that we might get from a middle age group, which is great. So it identifies for me, because those would have been the top things I would put on the list. But it's important to know who we're chatting with, the reasons, and why it's important to actually have those conversations with individuals. It's not hard to develop a long list of kind of benefits. Then you can obviously add to this list in a big way. But the chat we need to have with any individual is what is their perceived benefit or non-benefit of exercise, because there's certainly lots of them, and I think we're capturing some of the ones that came up here. The other thing that we should think about is that there's always two sides to it. While in this room it's obvious why we should be active on a regular basis, but maybe even for the folks in the room, on a daily basis, sometimes there's this challenge, right? And certainly I face it. Do I run today? Or do I get that project done and the report that's overdue? Or should I just go run? And there's always this kind of trade-off balance. Do you know what that's like? You know what that's like? Can you run and do your work at the same time? That's kind of tough. I can't keyboard and run so well. But for others, it might even be more fundamental that, there's this strong commitment to continue what folks are doing, and especially with older adults, right? They're committed to their lifestyles. They like to smoke, they like to drink, they like to eat, and they like to be inactive because that makes them very happy to be in that space. And the thought of changing is actually painful to them. If we don't understand what's going on there, then it's hard to really get to the next levels. And if we don't lay this out, it's actually sometimes not even obvious why they have such strong commitments to stay the same. If anybody want to get deeper into change theory, there's some very interesting references, including one called immunity to change. That the things that we do, anybody try to change experiment on yourself, on somebody else? Anybody done a change experiment where it hasn't worked? I'm going to, January 1st, I'm going to change something about myself, but then a few months later you find yourself doing exactly the same things that you used to do. And you say, well, that's just my personality. Well, sometimes it's just my commitment to doing the things that I do are so strongly ingrained that if I don't understand that, I'm not going to get to any change. So continuing the behavior the same way is sometimes our strongest commitments to ourselves, not to be dismissed. So helping people with behavior change, where to begin? Let's ask some questions around motivation. Why is this important to you? Do you think this is a problem? Are you interested in a change, getting at some of those trans-theoretical model? Why do you want to change? And getting to those personal reasons of benefits. Are you ready to change now? And what are you willing to do to make this happen? So try to get those commitments, small steps, before we get to the, here's what I think you should do. Thinking about barriers, because we all have barriers that we face. And if we don't identify them, we're not going to get very far. And there's lots of barriers that people would identify. Time, money. You can save money. We don't need extra time to do this, so we build this into our daily lives. It's inconvenient. I don't have the self-motivation. I don't have the confidence, so let's build that up. So figure out what are those things that we need to really work on. It's not enjoyable, it's boring, so can we make it fun in some way? Their fear of being injured, and maybe that's because of some past experiences, absolutely. And sometimes our patients will tell us this, I'm not going out for a walk, I will hurt something. So let's figure out what's the safe way of doing these sorts of things. Identify them, and only if we know them, then can we develop solutions for that. So here's the question that I will ask then, and maybe this is tip number 2 of, are you getting enough? So in every encounter with every individual, ask this question. Are you getting enough? And are you getting enough minutes of exercise per day, of course? And that's the real kind of question. We would even put this into the exercise as medicine framework as a new vital sign of documenting the number of minutes of exercise per day that people are getting, exercise and physical activity. Why is that important? That patients don't think that this is an important thing unless you ask it. You may think that it's important, but if it's not regularly, routinely asked, then people don't think it's important. The converse, when you see your doc, or your nurse, or a healthcare professional, and they're checking your blood pressure, for instance, and every time you go, you get your blood pressure checked. Patient thinks, well, this must be really important. They keep doing that thing on my arm. Whatever it is, it must be important because they keep measuring it every time, and they ask me about it. For people living with diabetes, they ask me about my blood sugar every time. It must be important. In fact, I should probably do something about it because the next time I come in, they're going to ask me about it. So if nothing else about our practices, if we can somehow integrate this question as a priority into every encounter, then that makes it exciting and make it like a vital sign. And that can be our brief counseling tip number 2. Don't sit, and let's just find out what people are doing. Again, figure out what people are doing, and then once you've done that, it's an easy step to say, well, here's what the guideline would say. And we know the guideline would say 150 minutes, and sedentary time or screen time is less than 2 hours per day. Does anybody get less than 2 hours of screen time per day? That's stuff. So we've got to re-engineer, rethink that one. Can I make my screen time somehow more active, which is interesting. And make sure that we move. Even if we have a screen, let's make sure we move with it. Finally, we can get to something around the exercise prescription. You're going to do some cases where you're going to do this a whole lot more. You're going to hear this term called FIT, which is a nice kind of construct. Again, for my medical colleagues in the audience, when I went through medicine, we didn't learn anything about this at all. And I would prescribe exercise simply by telling people to go exercise. My analogy to that would be, I would never think of giving a person living with diabetes, here's some insulin. Good luck. Take some. I'll check in with you in a month. How's it going? We would be pretty precise about, here's this insulin. I want you to draw it up in a needle or take it from this pen, dial up 20 units, inject it into your right thigh, day 1, left thigh, day 2, upper abdomen, lower abdomen, keep rotating those sites. If you get weak and shaky, that means your sugar's gone too low. Maybe we need to back off on the insulin. I want you to call me. On the other hand, when you're checking your sugars, if they're still running really high, we might need to give you some more. Please give me a call and we'll adjust those kinds of doses. If you're getting some, like a red abscess at the site of your injection, that could be a problem. Let me know and we'll have a conversation about that. We get very specific on how we generate that kind of medical prescription. We need that specificity as well around the exercise prescription. Good luck is not good enough. So, frequency, intensity, not too much, not too little, but just right. Use the large muscle groups and do this in sufficient time. We're trying to get to the 150 minutes per week. Typically that's 30 minutes a day, 5 days a week, but it could be in greater or lesser bouts depending on what's available to us on a regular basis. And we can also break this up right into 10-minute bouts, morning, afternoon, evening, for instance. So when I try to get in front of my medical colleagues who don't understand a lot about exercise, and I don't either, but here's what I've learned from my good exercise kinesiology friends, is that exercise prescription is like this analogy of Goldilocks. And what do I mean by that? So of the 3 beds that Goldilocks tried out, one was too hard, the other one was too soft, and the third one was just right, and the oatmeal was too hot, too cold, just right. So exercise prescription is that way as well. Not too much, not too little, but just right. And what do we mean by that physiologically? Some of you would be able to do this better than I. But if we look at how the human responds to exercise activity, if we increase the amount of workload that one does, the intensity of exercise, and then look at what happens to various responses. So the purple line, for instance, is heart rate. Heart rate starts at about 60, goes up to 160, and has this nice linear relationship. VE, the red line, stands for ventilation. We breathe about 15 liters of air at rest. That can triple and go up to 45 liters per air. The purpose of breathing more and more is to bring in more oxygen in terms of quantity into our lungs so that we can consume it. So the orange line, the blue line is VO2 or oxygen consumption as it goes up as the organism exercises and generates energy internally. The orange line is carbon dioxide production, and that starts off very low. In the beginning, for the first 2/3 of this graph, we have an oxygen excess. We are aerobic animals. And then for the latter part, we have carbon dioxide excess. We become anaerobic in nature. The place where this stuff crossovers is anaerobic threshold. So if we have that little bit of physiology as an understanding, what did Goldilocks tell us about exercise prescription? Not too much, not too little, but just right is the place that we try to go to. How can we do that? We can do this scientifically in a few different ways. So heart rate, my friend, that you were asking about. So we can do things like heart rate reserves, figure out what's the right zone here. If we actually did physiologic measures, those of you who are doing exercise phys labs and doing VO2 measures, we can actually calculate where you sit here. And then kind of practically, we can also just ask people just to get a little bit shorter breath. And when you're getting a little bit shorter breath, you're crossing over from aerobic to anaerobic, and you're just kind of right. If you exercise in those zones, then you're actually getting cardiovascular adaptation. For the older client, you don't need to exercise them here, but this is what they think you mean when you say go exercise. Exercise to your peak, max out your heart rate, get sweaty, get nauseated, throw up. Because that's what's seen on television, right? The first workout on The Biggest Loser is always associated with putting people on treadmills until they fall off, get injured, or throw up, right? And that's their image, which is not pleasant, which is painful, which actually causes injury, and will lead people to never come back to it again. And I think you all recognize that. So it's finding that sweet spot. It's really, really important at the anaerobic threshold. So when we generate an exercise prescription, we can bear that in mind. And this notion that writing things down actually legitimizes the transaction. I think that's important, right? Patients in medical interactions often expect, well, I'm not leaving here until I get the prescription. So if we can actually exploit that kind of relationship and transform it into something that's more positive, then that will be useful to us. and it has these attributes of that fit prescription that mirrors what we might do with medication prescriptions as well. And there's good literature to say that endorsement by a healthcare practitioner is a strong motivator for success. People will be more successful if you strongly endorse this as well. Exercise Medicine Canada has its own versions of prescription forms. We don't have here, right?
Yeah, everyone's gonna get it.
Everyone's going to get one, so you'll be able to work with these things specifically, which makes the prescriptions even easier because it's kind of laid out in that logical format, and you can take advantage of kind of circling numbers along the way, which is very nice. So brief counseling tip number 3 was that you can exploit those simple prescriptions, make the transaction live, people walk away with a piece of paper, and there's less kind of confusion about what was actually discussed during the course of that conversation, which is great. The way you might use this, and this mirrors some of the exercise prescriptions that you're going to do, if we have this young woman or a middle-aged woman who is otherwise well except for high blood pressure, and she's walking 20 or 30 minutes a day, 3 to 4 times a week, and she'd like to maintain good health over the long term, what might we do with her and use the prescription? So if she's walking 2 or 3 times a week, why don't we increase her frequency to 4 or 5? If she has a light intensity, we can increase the intensity, make it more moderate. We can look at those times. And also, if you want to exploit some other ways of getting intensity, we can get her walk faster, or we can use some slopes in the neighborhood. Walk up hills, and then you're going to work a little bit harder, and then follow up. So that's one prescription that might work for us. If you had a 39-year-old guy who works on computers all the time, and he's developing diabetes and high blood pressure and all kinds of other bad things, and he sits all the time, then we might use the prescription instead to say, let's really focus on sedentary behavior here. Let's get you to start moving a little bit more than you're using before. Let's get you to use some stairs. And the frequency of actually programmed activity might be quite minimal in the beginning. Just get you to start moving a little bit more would be the goal. And then if you had somebody who's actually kind of a trained runner already and is looking to really enhance performance, and she's had a history of injury, for instance, then this would be the time to call in on your friends that know a little bit more about exercise physiology, that know more about biomechanics, and say, let's get you to a running specific clinic, a sports medicine clinic, and we're not going to even try to do the exercise prescription in that place, but let's get you connected into people that might be more knowledgeable. There's a version of this that's also been developed for people with diabetes that has this same sort of pattern, trying to simplify the exercise prescription. And if you categorize people just by where they're starting, and then just taking it up one more level, that might be another simple approach. And you can have these prescriptions as well from the Canadian Diabetes Association. So if you're not moving, start to move. If you're moving regularly, then do it a little bit more frequently. Add in some resistance exercise, either at the beginning or in a more comprehensive manner. The other kinds of opportunities, so people are looking for time to do things, right? Nobody wants to kind of extend out your days, and I'm grateful that you're here. Some good medical colleagues have exploited this notion. And we're all familiar with the walk-in clinic concept, right? And that could be for medical care, it could be for dental care, it could be for nursing care, physiotherapy, anything. So the idea behind a walk-in clinic was that you're trying to make it more convenient for somebody to get to you and access your services, right, on their demand schedule. What if we instead had these notions of walk-in clinics? So colleagues that run a diabetes program at the Toronto East General, they thought, instead of us seeing people with diabetes in the usual way, you come in, sit down in the office, let's have a chat about how's your sugar control, how are your feet, how are your eyes, how are your kidneys, how's the family, how's your dog, and then you'll leave the appointment after that and go to the next room and see a dietitian and have a conversation, and then go see the nurse. What if instead we got all the people that were coming in over the next hour to come in all at once? So 6 people will come in at 6 o'clock. The first thing we'll do is we'll all check our sugars. The second thing we'll do, we'll put on our running shoes. And then we're going to leave the building and go for a walk around University Avenue. And during that 1 hour, the patient gets to rotate between professionals, all of them, and spend a little bit of time with each person. During that time, they get all the counseling that they need, including spending time with each other. At the end of the visit, you all come back and you check your sugars, and you realize your sugars have actually come down by about 10 or 20%. And you recognize that, wow, this walking thing that actually can kind of help me in terms of health. The staff are all happier because you actually got for a walk yourself, and your mood is improved by doing so. And the physician is happy because he or she can actually bill for the appointment. So financially you've lost nothing, time you've lost nothing, but everybody's gotten healthier. And patients then realize, well, the normal thing for us to do when we get together is actually go work. And it's actually powerful. So exploiting those kinds of opportunities. Opportunities are indeed everywhere for us. We just have to find them. Here's one more thing you can YouTube if you want. And this is kind of, if you just Google piano steps. The quick story here is that this is in Denmark, I believe, where the typical construct of a subway platform, and as you're going up from the subway, well, my friend has gone off the subway. If you have an escalator and a stair, what's the direction that people choose? Escalator. Why? Just because it's more convenient and everything, right? So that was the experiment, and about 95% of people would choose an escalator over taking the stairs. So what these guys did, these fun engineers, was they put actually musical piano overlays on the staircase, and they would actually make noise, a musical tone whenever they would step on the step. They were able to transform the number of people that would then take an escalator versus taking stairs. And about 80% of people started using stairs instead of escalator. So if you make kind of interesting environments, then that would be a way of nudging along positive health behavior. We could do an experiment at St. Patrick's Station. Let's put up some stairs and see what happens. A whole series of things might be helpful for developing self-efficacy, and the range of things are, if we have some kind of monitoring device, whether it's a simple pedometer, whether it's a souped-up bracelet, or whether it's a simple written diary, that people are more successful with their health behaviors if they actually track it and monitor it themselves. You can layer in a layer of supervision on top of that. If you're accountable to somebody, then you might actually transform behavior even more. Leverage groups and peer support. Those are extremely important as well in helping people be successful. And then finally, at the end of this kind of counseling thing, is to think about relapse from the beginning. None of us are perfect. We will all start activities, but then we're going to stop them again. And the real magic is having the plan of when we stop, because we are going to relapse at some point. If we plan for that ahead of time, then we can be successful in terms of sticking with something. So, long construct, we don't have to do it all, but there are pieces in there that actually form a frame. Hopefully it will inform some of your case discussions, but here's a few things that we can think about. If we do it well, then literature would say that this is how we can be successful, and actually a randomized trial would say, if we use the typical medical model of I will tell you what to do, what was seen in that trial was exactly what we thought. That people will resist and they actually become inactive, more inactive than they were at the beginning of the study. If we actually are thoughtful about addressing where people are, what barriers they have, thinking about solutions, they will gain about an hour of physical activity per week. So we can actually help them get towards their goals and be successful in that way. Final thought is this one. I've spent a lot of time on planes recently, and there's this spiel that happens all the time. How do we adapt this spiel to this construct that we're having right now? What does this mean? Anybody want to interpret this for me? Sir?
Maybe help yourself before helping others.
Yeah, there we go. So what if there is a very cute child that is sitting next to you and the oxygen mask drops? Who gets the mask? Beautiful child, adorable. Turning blue now though. Who gets the oxygen mask? Anybody? Who gets the oxygen? Let's just say it. It's okay. We won't think badly of you. You do, right? Because if you don't help yourself, then you can't help anybody else. And that's really important. So grief counseling tip number 5 that maybe is redundant for the folks in this room is that if you lead by example, then good things will happen. For medical audiences, I bring this up because often, unfortunately, medical practitioners, as they get established in their practices, may become less active than is ideal. It is much easier to enter into this conversation if you're actually doing it yourself. It is much easier for patients, to actually embrace this if they see this is what the normal thing is to do. So, continue the great activities that you're doing. So in summary, we believe that exercise physical activity provides important benefits. Heart disease, chronic disease prevention, management. If we do this structured appropriately, we can be very, very effective and can really help people. Think about the common barriers, motivators, simple, powerful messages to encourage exercise. And every one of us, wherever we're coming from, wherever we're going to be, has a role to play since all Canadians can benefit from this sort of construct. Thank you for your time, attention. That was a pretty dense lecture for a whole hour. Thank you for sticking with us, but hopefully this will set up the framework for the next part to come. Thanks.